Greg Benevent from Website Depot, here with another Website Depot podcast. Today, I'm taking some time to talk to another great client of ours, one that's really going to be able to help a lot of people, has already, and is going to be able to do even more at Sal Psychiatry Services and Sal Rediscovery Center. They've been able to already kind of help people along the journey of recovery to overcome addiction and improve their mental health. I'm very happy today to be joined by Earl Carroll, the program director at Sal Rediscovery Center, and Dr. Aikoye, Dr. Sal himself. Hello, I'm Greg. Thank you so much for taking the time to talk to me today.
Yes, absolutely.
Thank you. I appreciate that.
Great. All right. So, now that we've got you here, if you could take a minute just to kind of tell me and the people watching and listening here a little bit about who you are and what it is that you do.
Okay. I guess I will go first. Like you rightly said, Dr. Aikoye. People call me Dr. Sal. So it doesn't matter which one you call. I will definitely respond. The CEO, Sal Psychiatry Services and Sal Rediscovery Center. I'm a double-boarded adult and addiction psychiatrist. That just simply means I see mostly adult patients with mental health concerns. And of course, I see patients with substance use disorders as well, what people call addiction. So if you call it substance abuse, substance addiction, substance use disorders, they're all one and the same. It's just a transitioning from more stigmatizing words to less stigmatizing words. So whichever one you call it, it's still one and the same thing. I'm pretty passionate about mental health and substance use as well. You see patients not doing well, seeing a lot of providers out there. So I felt, okay, I think it's time to try to come up with my own practice so I can do my own thing the way I know that patients do respond to pretty well. And then I started with the Sal Psychiatry Services, which, of course, before you know it, we branched out to Sal Rediscovery Center, which deals with patients with not just mental health now, with substance use disorders. That's what they call dual diagnosis, co-occurring. So they have mental health concerns and then substance use disorders. And of course, when you look at the current practice, in fact, that's the recommendation now. You have to provide an integrative form of care. So patients can come to just one place, right? And they get everything they deserve, everything they need to get better. So you treat one thing and then you treat what's going on as well alongside. That's the co-occurring or the dual diagnosis. I've done this for a while now, and I think I love what I do. I don't see myself stopping anytime soon.
Well, that was very well said, Doctor. First question I had off the top of my head, and I think you might have touched on some of this in your answer. I was very struck by when you talked about you started these two facilities in part because you wanted to do your own thing. And, I've talked to a lot of people in the rehab space, and I'd be very curious to hear, and again, I think you might have touched on some of this, what you want, what to you is like, okay, what's doing it different? What is it that really makes the services you provide different than what someone might find somewhere else?
Thank you. I appreciate that. That's a pretty awesome question. That's the same question some of my patients ask me too when I see them for an initial evaluation or encounter. They tell me, "Oh, I've been here, I've been there. All I got was this, and that." And so, okay, that's okay. Let's start afresh. That's the whole purpose. Let's start afresh. Let me get to know you better. So my own thing is, do you know who you're talking to? Do you have an idea of who's sitting in front of you? Do you really care about who's sitting in front of you? Or is it just, oh, yeah, I take your insurance, just come in. Oh, let them do this, let them do that. I think that's what most patients go through. They go somewhere and they say, "Oh, okay." The first thing they asked me was, "What's your insurance coverage like?" Okay, what's the problem? 2 minutes, they are done. So for me, I listen to the patient, right? I listen to the patient. I hear what you're saying. We do this open-ended questioning, so it gives the patient the opportunity to really say what they want to say. And 15 minutes into the encounter, they tell me, "Okay, are we done yet?" I said, "Oh, sadly, we're not even close." We're not even close to being done yet. They say, "Oh, okay, I'm not used to this. I'm used to someone just asking me 3, 4, 5 questions and they're done." And so,
geez.
This is what's going on, and this is the medication. Just go pick it up. Rather than what's the right approach? What details do you need to provide a wholesome care? It's not just about the medication, right? Medication is easy to prescribe. All I have to do is just a stroke of my pen, right? I prescribe the medication and we're done. But mental health I see it as, it's much more than this. These patients are humans, first of all, right? Before mental health. And sadly, no one is immune to mental health problems. No one, no single person. If you look at it that way, then you see these patients as humans. Communication, you talk, you let them talk, you listen to them. You provide them all possible theories, because patients want to know what's possibly going on, right? It's not, "Oh yeah, you're hearing voices, right? Just take this medication and go." Where is this coming from? What do you think is wrong with me, doc? What options do I have? That's one thing patients never get. What options do I have? Are there options available that I can choose from? Patient-centered care. So my style, you listen, provide evidence-based treatment, and then, of course, patient-centered care. In fact, I know sometimes some patients see it as too pushy, meaning, "Doc, you are the doc. Why are you asking me what I want?" Right? But then I let them understand, if we're not on the same page, it's probably not going to work out. We both have to be on the same page. You have to understand what you're going through. You have to understand the options available. You have to understand which ones are, we call it evidence-based, meaning science-based, evidence-based. Which ones are the other part of it, the other side of it is off-label. Off-label just means it's not necessarily, "Oh my God, FDA approved," but research have shown that these things help and they work probably similar to the ones that are FDA approved. So they call it off-label use. So patient needs to understand all these things. So it's like, I take my time to explain these things, and they feel, "Oh, wow, this is a new thing for me. Okay, now someone is listening to me. Someone wants to listen to my own opinion, not just them throwing stuff at me." And then it's just building the rapport, building that relationship, building that trust, and patients feel more comfortable, and they choose where they want to start. You meet them where they want to start, and then you guys move on from there.
Wow, that is, I totally get that. I mean, I was struck by it's so much of just what I've seen of this space is that, and it's very much what you said, is that someone in your position, when someone says, "Hey, I need help," someone in your position is like, "Okay, here's the answer." Whereas you're saying, "Okay, here's multiple things it could be, and then we're going to talk about this and we're going to figure it out from there. But it's not just this one set thing that I know immediately from this. And it sounds like that's what, when you talk about integrative care, maybe this touch aspect of it is it doesn't just integrate a lot of different things. It also integrates you and the patient kind of working together in a way. Like that seems to be more of how, and please correct me if I'm wrong, but that's the centering of the care on the patient. Is that correct? Or
correct?
Okay.
Walking together. Yes, correct.
Together. That is a great symbol for that. I love that. Okay. I feel like we've touched on this, but I have to ask because I was very struck by the way you spoke. I mean, so much. Oftentimes when I talk to someone, and you can go back and see past episodes of this, where I talk to, someone in your position in the rehab space, and I'm like, hey, what, got you into this? And they'll say something like, well, I always very much loved this. And they'll talk about their qualifications. I got to say, I've done a lot of these, doctor. I think you're the first person I've ever heard actually use the word passion. I think that's a new one for me. So if you could, and obviously it comes through in all the things that you've said so far, just already. I'd love to hear you talk a little bit about, where you think that passion comes from, how that, motivates you each day. I mean, again, it's obvious, but I mean, I'd just like to hear you say a little bit more about that, because that's so fascinating to me, because I don't know, I've never necessarily seen so much of that in this space thus far.
Thank you. Yeah, for me, growing up, I grew up in a community where mental health was, minimally talked about. Anyone that tried to talk about mental health, oh my God, what are you talking about? That's either a spiritual thing. They should be an outcast. They shouldn't be heard at all. Mm-hmm. And then from high school, I tried to join a lot of these advocacy groups, and it's, oh my God, you're too young. Can you do this? I said, yeah, that's exactly what I want to do. Mm-hmm. And then I started with elder abuse, advocacy groups. Oh. Then there's this thing called disorganized schizophrenia, where they roam the streets and then people throw stuff at them. I got into that too. And then slowly I knew what I wanted to do, going into medical school. And then it's all about working with the community for me. And then once I started understanding why people think that way, why people are so much stigmatizing in their statements, in their encounters with patients with mental health, I beginning to look at things very differently. And then coming into substance use, the whole social theory just blew my mind. Social theory, they said, oh, it's your fault. You shouldn't have used it in the first place. What's wrong with you? Oh. And then I said, okay, no, it's all, no, this can't be right? And then later on, the whole substance use community started talking about medical model and how this is a chronic disease, how it should be treated the same as things like hypertension or diabetes, because they are chronic diseases as well. So it's just a graduation from how much I understood back then. And then the more I begin to understand why these things happen, the more I even became interested in pursuing that route. And then on top of mental health itself, substance use became something that I just couldn't run away from, because there's so much entangled, and it became so something of joy when we started talking, we meaning the whole psych community, started talking more about things like it's one and the same. Substance use or mental health, they should be seen as the same thing. You can't separate them. We shouldn't look at it that way, or else these patients will get any help at all. They say, okay, yeah, now we're talking. We're moving forward. And then the whole integrative model again just cemented everything. Get all the care needed in one place.
Okay. That's great. And again, that passion absolutely shines through. I mean, this is one of the rare times that the word joy has come up unbidden in one of my podcasts, and I'm very thankful to hear you say that. I think I'd love to hear you expand on a bit of that the last point you made about getting all of the care in one place. I mean, if you could talk about the benefits of that. I have some ideas as to what those might be, and also how you can help folks with that exact thing.
Thank you. Perfect question. For for most patients with mental health, naturally they're at a disadvantage already, right? Sometimes some kind of mental health disorders just comes with poor insight, poor judgment. They don't know this. They don't think this is what they should do. They have no clue what can be done. Sometimes they don't even believe anything should be done in the first place.
Oh,
right?
Geez.
That comes with that some kind of mental illness, poor insight. So if you technically don't have everything they need in one place, then naturally they just fall through the cracks. They fall through the cracks. So let's say you see a patient now with mental health diagnosis, and then they use substance, right? Sometimes it's a two-way traffic. The chicken before the egg, or the egg before the chicken kind of thing. Okay. You say stimulant, right? Then with stimulant, you can become psychotic, hear voices, feel paranoid, stuff like that. Stimulants like meth and cocaine, right? Sometimes it could be the cause of their primary problem, meaning the cause of their psychosis, right? But sometimes it's just the way around. Some patients start to hear voices, then they become paranoid. They might have the diagnosis of schizophrenia, but because they want to help themselves the best way they can, what do? They self-medicate. So now they self-medicate with drugs or alcohol, and let's say they use meth or something like that. Now you have a primary diagnosis, right? And then you have meth use. Even if you have a primary diagnosis, using meth, which is a stimulant, which can cause psychosis, will make things 10 times worse.
Right.
So let's say they come to you, oh yeah, you have schizophrenia, take this medication. And then they go back, they take the medication, they don't feel better, they feel it's useless. They might not necessarily come back. But once you talk to them about the diagnosis, you also have to talk to them about the substance use. That no matter what you do, as long as substance use is still in the picture, nothing works for you.
Oh, right. That makes all the sense in the world. The idea that, like, if you're not offering, like you said, that complete, care, any little gap is one more place for for lack of a better phrase, tragedy to strike or things to fall apart. That's where, since it's not complete, then it's almost like the chain breaking.
Correct.
And I wanted to ask, and again, you might have touched on this a bit. I mean, I've had, people come on and talk, and I've certainly done, writing for clients, talking about, as you mentioned earlier, dual diagnosis. And so much of what, I've seen when people talk about it has been, broad strokes, platitudes, just very basic. Whereas you certainly seem like someone that, and I appreciate this, seems to get into the details and the specifics. So I'd love to, if you can, just maybe give us, and I think you touched on some of this already, just a little bit more in depth about dual diagnosis, how it can help, what it consists of, that kind of thing, doctor.
Thank you. Dual diagnosis is, just to put it plain, right? Two sets of diagnosis. One, some people call primary, and the other, some people call secondary. At least to understand, it's okay, primary versus secondary. But to us, we try to use those terms as maybe minimal as possible, because it creates that dividing line that might just help perpetuate this idea of provide one, you don't have to worry about the other. Provide this, you don't have to worry about the other, right? But yes, to help people understand, right? Primary is the main thing you're going through. And then secondary is what comes after that. That's the dual diagnosis now. Plain example, very common example, depressed patients, right? Okay. They're so depressed, they want to self-medicate because that's just what they know, right? They drink alcohol. And then alcohol it's a depressant, meaning eventually makes you more depressed. But then there's that transient effect that comes with it, especially depending on the amount, right? There's a transient euphoric effect that can come with some level of use. And then, oh my God, it made me feel so much better. I think I should do this more often, right?
Oh, geez.
You just go back again and again and again and again. And then you end up with what we now call alcohol use disorder, because that's just the natural trend. The more you use, the more your body wants it, the more you go back. That's why they came up with just so many things that can help providers come up with a clear diagnosis of alcohol use disorder. So yeah, that's the dual diagnosis. That's how it can happen. And how to really tackle it is you tackle both. Tackle the depression, because if the depression doesn't get better, what happens? Of course, they go back again to drink. Doc, your pill it's not helping. This is what helped. I'm going back. And then if you tackle the depression, sometimes it just makes them feel a lot better, right? And they say, oh, wow, this medication is working. Maybe I shouldn't even drink anymore, right? Or maybe I should cut down. Maybe I don't need the alcohol. But it's not that easy, because it has progressed to a use disorder. So use disorder just means it's hard for you to stop on your own. So that's where the help comes in. So you treat the depression, which will make use probably less, but it might not go away, because I will use the word addiction, but we use disorder now because addiction has set in. So you have to treat that addiction too. And then, of course, you treat the depression, so the patient does better. All research you find out there shows that treating both help them do better, and treating both at the same place helps them do even better.
That's great. No, that explained it so well. That's the clearest and most concise, as well as comprehensive, that anyone has ever explained to me, the idea of dual diagnosis. Thank you for that. This almost feels like a silly question to ask, because I feel like it's what you've been saying in different ways throughout the course of our time together. But, if someone does come to either of your locations, if you could tell us a little bit about, what they'll expect, what you can provide for them when they arrive, getting started, all that kind of thing.
Perfect question for the program manager. So Earl is going to answer some of it, but I'm going to tell.
Great. I was feeling bad. I was like, I just want to times we have 3 people and I haven't passed it around well, because it's not like we're all sitting at the desk together. Thank you, doctor. That made my job much easier.
I'm going to tell them what to expect from me.
Okay, good. Okay. Thank you, doctor.
Expectations will be, it's going to be all about you. All about you. That's what I care about. So it's going to be listening, basic questioning to help me come up with theories, or we call it differential, but just basically theories of what's going on. And then I can assure you that it's always evidence-based first. Evidence-based treatment. And of course, patient-centered. That's what you should expect from me. If you get anything less, talk to the program, the manager. the manager knows how to deal with me.
I have to say, I've worked in this field for about 4 years now, and I've worked at many facilities all the way from San Diego all the way up now to Norwalk, California. They're beautiful facilities, and they have a lot of good people working there. But the person that owns the facility hires a doctor to write prescriptions. That's all they do.
Oh, geez.
When I came in, and I saw a lot of issues with that. I see a lot of clients, working in residential treatment where, just like Dr. Aikoye said, they're not really paying attention to the other half, the core issue, because usually drugs or alcohol, it's just a symptom of something deeper. It always is. So coming on here with Sal Rediscovery Center, I saw something very, very special that I haven't yet seen before from San Diego all the way up to this area, was that there was a doctor out there that wanted to do this for himself and actually provide evidence-based care and patient-centered care where you're not a number. There's a lot of places you go through there, they're looking at you like, we need to fill this place up to make a certain amount of money because we're a corporation.
Oh yeah.
I'm not going to knock a lot of places, I've worked at a ton of places where I feel like I've done some good work, and I've come through treatment myself. I'm in recovery. I'm almost about 5 years now.
Hey, congratulations.
No, thank you. So, coming through it and getting to this area, what you can expect over here is you have a doctor that absolutely cares about you from the bottom of his heart, and you can feel it. And you come into our building. All of the staff here is very, very. They care about you and we do one-on-one. We meet you where you're at, and you're heard. You're not just okay, go get to group and leave. It's more comprehensive than that, and I think it's really, really needed in what's going on right now, especially with the fentanyl crisis that's just reaping our community. It's there's so much that needs to be tackled, and I don't believe it's being tackled in the correct way. And I believe that Dr. Aikoye, what he's doing here, being able to treat clients that maybe not have the best insurance, they're coming from Medi-Cal insurance or stuff like that, being able to treat those clients that absolutely need it. And I'm really happy to work here because this is the first place I've seen where it's really, there's care for the client. Absolute care.
Thank you for saying that. That was very well said. I think, with the things you're saying, just come through and what we've discussed today. I have to ask you a follow-up question because I was very struck by one thing in particular you said that I'm not sure I've heard worded to me in as many words as you did. If you could say a little bit more about the idea about meeting the client where they are. I think that you kind of touched on a little bit after that, but if you get into a little bit more of what that means, because wow, did that sound great and sound like the kind of thing that, someone on the fence about, should I get treatment, should I not, or where should I get it? That seems like that's the kind of thing that they could definitely hear more about.
When I say meeting the client where they're at, just like Dr. Aikoye said, when you're in the addiction and you're in the depression and you're in that whirlwind of just destruction to your life, you don't really know how to get out of it. And you can be thrown into a treatment center and, go through the motions, but still not get it because you're just going through the motions. So when you come here and you first meet with Dr. Aikoye and he's like, hey, gets in front of him and says, hey, you're looking at me like I care about you. What is it that's really going on? And really having that conversation, because other places I've worked at, the doctor gets in the room and it's like, okay, you're depressed. Oh, you're probably bipolar. Okay, so let me make sure that I get you this medication. You're probably bipolar. If it doesn't work in another 2 weeks, then we'll do something else. Have a good day. And it's maybe a 10-minute conversation. And it's just, like you can't help the type of population that's out there. Maybe some of them, but a lot of these people have some deep-rooted problems, and they need someone to listen to them because they haven't been listened to their whole entire life. So when you come at it from that angle, and the client walks in and they've never been treated like that before, there's a spark that happens, and then they start to want their treatment. They start to want to get better because they have people that actually believe in them, and no one's ever believed in them in their whole life. So that's why I really believe in that, and I haven't been able to find it till I got here. That you'll get a therapist or you'll get a case manager that cares, but like the doctor that actually knows what's going on up here, what's going on physically, actually involved, as much as Dr. Aikoye is involved. So I would say that would answer that question. Yeah.
That was very profound. Thank you for sharing that. I was genuinely moved by that. That was great. Wow. Guys, folks, I could talk to you both all day. I mean, I really could. I mean, I every time I come on here, I always say I learned something, but this in particular, I learned quite a bit today. Is there anything that I didn't ask either of you about that you would like to say, to somebody that's, not sure whether they should get treatment, or anything that you'd like to add that I didn't ask you about?
I will say this, and I'll be very upfront. I come from a history. I got a back injury when I was 18 years old. I was thrown on the opiate pain medication, and I stayed on that opiate pain medication for a very long time, and it actually turned into a heroin and meth addiction. That was also like an intravenous addiction. So I've been through many things to where I thought, life wasn't worth living. I didn't think I would ever make it out. Been homeless, been incarcerated. But anybody out there that's really truly struggling with addiction, I want you to look at my face and realize, like, I was that person that had scabs all over his face and couldn't even walk down the street because someone was going to call the authorities because there's a crackhead on the street. And if you want a different life, there are services out there, and you can definitely come in our doors and you will not be ignored. There is hope. There is help. We do recover. But I just want to stress that I recovered. I'm 5 years. My recovery date is 9/19/2018, and it's possible. It's not impossible. I thought it was impossible, but it's not. And there's help out there. Get help. Reach out. Do whatever you need to do, because life is worth living once you find your niche.
Absolutely. I think he has said all, but the bottom line is, it's not impossible. It's not impossible. There's always, I always tell my patients, there's always that next option and the next option and the next option. The options never end. So there's no, I think I'm done. And there's no, I think it's over. There's always that next thing to do. Sometimes they get surprised. No, they've done everything.
Ever changing.
There's always that next option. So just start somewhere. That's the idea. You start somewhere and things just keep going. Of course, the nature of the disease is ups and downs. They say you go in and out, but there's always that next step for the patient. So start somewhere. We're always here. Give us a call, stop by, talk to someone, and see what options you have available for you.
Folks, thank you so much for coming on today to talk to me, to share with our viewers and our listeners. That was genuinely helpful. We're going to have your contact info come up here on the screen so that people know where they can reach out to you. And again, Dr. Sal, Earl, thank you so much for coming on with me today. I genuinely enjoyed it, and I got a lot out of it, and I imagine, and I know the people listening and watching did as well.
Absolutely. Thank you so much.
Thank you. It's nice being here. Thanks.
It's great to have you. All right. Well, on behalf of Website Depot, my name is Greg Benevent. Thank you so much. Take it easy. Have a good night.